Hi, I'm Eddie So with DKB Med. What you're about to watch is a recording from a live presentation at the First Baptist Church in Frankfort, Kentucky on November 17th, 2025. DKB Med partnered with the University of Kentucky, Bishop Hill, and his congregation for this engaging discussion about Alzheimer's disease and the impact clergy members have on their congregants. Please enjoy.
We have two speakers today. We have Dr. Fred Schmidt, who's a neuropsychologist at the University of Kentucky. He's worked for 40 years, at the Alzheimer's Disease Research Center at Kentucky. He was one of the founding faculty members and scientists for that center and program. So we're really excited to have him here today. We also have Dr. Willie McBride, who's another neuropsychologist at the University of Kentucky. He is active in seeing patients and helping people with their memory loss and getting assessed and things like that. He's from Louisville, but he joined us in Lexington. I think you still live in Louisville. So he commutes, he passes through Frankfort on a regular basis, but they both have some great resources for you all. I am here often with the Healthy Aging Workshop Series, so I see lots of familiar faces, but if you all have any questions, we can follow up after the meeting, or feel free to reach out at any time. It's so great to see you guys today, and thank you for your time. I'm going to turn it over to Dr. McBride.
Hello, everyone. Good afternoon. So I'll be your intro speaker for this great talk that we're having this afternoon with Dr. Schmidt, who has been giving me some mentorship and guidance on doing these great talks. So I'm happy to be following in his footsteps and talking about a topic that is very important and very integral to the communities that I serve and that we serve at Sanders Brown Center on Aging. The topic of this talk, or this afternoon discussion, Saving Souls, Alzheimer's Outreach, Granting Peace of Mind, okay? Like Dr. Rodas said, I'm originally from Louisville, Kentucky, born and raised, started at UK in about 4 or 5 months ago, so I'm really happy about the work that I get to be involved in and the things that we get to talk about. So our topics today are going to be on the role of social determinants of health in Alzheimer's disease prevalence, and then the importance of early diagnosis and intervention, okay? And then reducing the stigma and initiating difficult conversations about AD and aging, Alzheimer's disease and aging. And so just kind of a quick question, how many of you all have either Alzheimer's disease or dementia has impacted someone, a loved one, friend, family member in your life? Okay. So probably over half of the people in this room have had some kind of interaction or know something about Alzheimer's disease. So that's great. That's great to hear. So what is Alzheimer's disease? Okay. It's about 7 million Americans in the United States have Alzheimer's disease, okay? Alzheimer's disease is the leading cause of dementia, okay? So dementia you think of as this, sometimes you get questions about, what is dementia? Is it Alzheimer's disease? Oh, well, I have Alzheimer's disease, I don't have dementia, okay? Well, what are we talking about? And we'll get into a little bit of that as well when we're talking about what is it that is causing people to have dementia. So dementia is an umbrella term, okay? It's a catch-all term. Alzheimer's disease is a subtype. It's a type of dementia that people often get, okay? Alzheimer's disease is the leading cause of dementia, okay? So when we think of dementias, people probably associate Alzheimer's disease with dementia. But there are other types, but one of the biggest causes of dementia is Alzheimer's disease, okay? Age is the biggest risk factor. So once you get to a certain age, your risk for developing Alzheimer's disease increases with each year, okay? So typically when we start to hit a certain age, just like kind of similar to after a certain age, you have to go start getting certain types of screeners or certain types of checkups because you're at an age where this becomes more of a risk factor for you. Alzheimer's disease is the same thing. About half of the people diagnosed with dementia have been diagnosed, and only 60% of those diagnosed or their caregivers are aware of their diagnosis, okay? So there are a lot of people out here who either the family or other people don't know that this person might have Alzheimer's disease, okay? So we're not catching everyone that is potentially having cognitive issues or things that are causing problems in their life. And that's a big deal, okay? Part of my job is to help people to understand and be aware and look for the signs of, hey, somebody's having some cognitive issues, okay? African Americans are less likely than white individuals to be aware of their diagnoses, okay? So now we're talking about, hey, do you even know that this is an issue for you? It's a problem for where African Americans or people from the Black community are not aware that this is a problem for themselves or for other family members, okay? And it's part of one of the reasons why we are doing these types of talks. And so on the second page, you'll probably see that there is a graph. And what it's really getting at is that our society is we are getting older, we're getting grayer, we're living longer just as a society, okay? And, barring, let's say we find a cure for Alzheimer's disease in the next 2 or 3 years, great work, but barring any kind of breakthroughs like that, we're expected to see about 13.8 million people living with Alzheimer's disease by 2060, okay? So we're gonna, as we continue to live longer, we're going to see more diseases that come along with older age. Alzheimer's disease is going to be one of the biggest ones, okay? On this next slide, where there's a graph here, I would say it's second slide on page 2, Black individuals face nearly twice the rate of developing Alzheimer's disease, the prevalence, okay? I'm going to say that again. Black individuals face nearly twice the rate of Alzheimer's disease than other individuals, okay? Why is that? Part of those reasons is racism, okay? Education, okay? And then socioeconomic lack of resources or availability of resources, okay? There's a slide that I really appreciate, the next slide on page 2, or the third slide on page 2, and it talked about something called the Human Genome Project back in 2001, where it was like, hey, we want to map the entire human genetic makeup, all of our code. And what was notable is that people alive today are 99.9% similar at the DNA level. Genetic variations account for about 1% of all of those variations. And so what does that mean, right? And so it goes back to that most previous slide of, why are African Americans getting hit with Alzheimer's disease at a higher rate than other people? Is it because there's something inherently different about a Black person's genetic makeup? And that's not the case, okay? What is more common is that there's socioeconomic issues, there's racism, and there's this word that, health diseases that tend to hit African Americans at a higher rate than others. Okay, so it's not that there's something inherently in your DNA, it's other things that are going on environmentally that impact Black communities. And if that gives you any food for thought, write down questions if you want to ask some more about that, because we would love to kind of dig into those things and talk about, well, what are the things that are impacting Black communities more to where they get Alzheimer's disease, okay? So on the next slide on page 3, the first slide, early diagnosis, okay? So part of my job as a neuropsychologist is I get referrals from family medicine docs, from neurologists, from psychiatrists, where people who are asking are saying, hey, this person has some memory issues. We need to figure out what's going on and what's causing those memory issues, okay? And so earlier diagnosis for just about any of our health conditions is going to put us in a better position to be able to manage them, get in front of it, take care of it, prevent it from getting worse. Alzheimer's disease is the same way, okay? So with Alzheimer's disease, it's a progressive condition, meaning that if you're starting up here and you're cognitively intact, you're gonna continue to see, you're gonna go downhill, okay? So there's no cure for Alzheimer's disease. You're going to continue to see a steady decline of cognitive issues, and we can talk more about when we say cognitive issues. That's a term we use to describe my thinking, my memory, my ability to focus. Right? I get lost or distracted while I'm driving. Those types of things. Okay. So when you have Alzheimer's disease, that is going to keep going down and getting worse. Okay, and so we don't want that. Earlier diagnosis can prepare patients and their families for future care. You wouldn't believe how many conversations I have to have with families about advanced care planning. You got a power of attorney established. Do you have a living will? Who's going to take care of you? Is grandma living home alone? Right? Those are kind of conversations that we often have to have when we're doing those types of things. Quicker access to treatments. There are some treatments that are out there that are known to help reduce the symptoms. And when you don't know that you have Alzheimer's disease, those symptoms cause more problems in our day-to-day lives, and probably cause problems for all of those people around us, okay? And it could stave off the progression. If you know that this is on the horizon for you, we might be able to do other activities, other things to help people in their day-to-day lives, okay? So if you know earlier, now I can do things to kind of keep me where I want to be able to manage my own day-to-day stuff, and so that I don't get worse or decline as I get older. Okay? Improve the quality of life. Okay? So one of my goals, people don't like to come see us, Dr. Schmidt and I. When they hear neuropsychologists, they're like, oh, okay, I don't want to talk to you anymore. Right? And so my goal truly is to keep people in their comfort and their quality of life as long as I can. The only issue comes is when maintaining that quality of life also puts you at a risk for being hurt, right? So then now Dr. McBride or Dr. Schmidt, we have to step in and say, okay, hey, we have to have some conversations about these things. So my goal is to keep people as healthy and living as long as they can in their own space and doing whatever they can. But we do have to have conversations about that stuff, and part of it is that we want to make sure that your quality of life stays as independent as possible for as long as you can, okay? And then if some of these treatments, if we're able to catch the disease earlier in life or earlier in the process, some of the treatments may have a bigger bang for your buck than if we wait till when it's too late to do the impacts or to treat it, right? Because at some point, if it gets so bad, there might not be a lot of treatments or things that can be done to help those individuals, okay? So it's so important that early diagnosis, early detection, catching it early is gonna be important, okay? And Dr. Schmidt will definitely be talking about some of the medications and things out there that where have we come in terms of taking care of or treating Alzheimer's disease. Most people who ultimately receive the diagnosis have usually waited about 2 to 5 years after the actual symptoms have started. So what that means is that, again, it's this slow, progressive decline where you start to maybe notice some more changes in your abilities and things. And oftentimes we don't catch it. We don't know, hey, it started exactly on this day, on November 12th or 2024 or 2023. But we usually catch it when it's starting to impact people more in their day-to-day lives where somebody else is maybe noticing it, or it's getting to the point where it's getting so bad that you're now starting to have a lot more difficulties, okay? So that's why catching it early is so important. It's because sometimes even when we catch it early, there might have been signs that something was going on even before you came in to see us, okay? Delayed diagnosis impacts African Americans and even Hispanic individuals greater than others, okay? And Black and Hispanic individuals typically have a later wait time from when they're actually given a diagnosis, okay? And we can talk about some reasons why that might be the case. And then white patients are typically referred, so they come to see us sooner than other people of other backgrounds, okay? So just getting in to see the providers, even the awareness of the diagnosis or the issues that are going along with it, Black and brown people tend to get to the table a little later than others. So on the next slide, on page 3 of the third slide, so it really is talking about the phasing of how does it start. So with what we know about Alzheimer's disease is that symptoms tend to start very slowly, gradually, and there might even be a phase where we call it the preclinical phase, where there might be some changes, but you don't notice it. It's not impacting you big enough to where it's impacting your day-to-day functioning, okay? Then people typically enter this phase called the mild cognitive impairment phase, okay? We call it MCI. And that's where you're having some mild symptoms, and you might notice, hey, I'm doing things a little slower. It took me longer to get my taxes done, or different things, that you notice some changes, but I'm getting older, I've lost a step, right? Then we transition into this dementia stage, where it's now you meet criteria for what we call like dementia, okay? And you are having some interference in your day-to-day activities. So the big, we call them instrumental activities of daily living. Your instrumental ADLs, driving, managing your finances, preparing a meal, using a computer, doing laundry, all of those types of things. Those are your instrumental. These are the things I do for my day-to-day life, right? We ask questions about those things. Well, why does Dr. So-and-so want to know how well I do laundry, right? He's asking about the starch, and I don't ask about the starch or any of that kind of stuff. But we ask those questions. Are you getting lost? Are you having trouble navigating places? We want to see, are you being impacted in your day-to-day functioning to the point where other people are having to drive you around, or somebody else has had to start giving you oversight? Hey, let me see your bank account, make sure you're not overdrafting, or you forgot to pay this bill. We ask all those kind of questions. So when someone's in this mild dementia stage, they're having some difficulties in those areas, okay? When you get to the moderate and severe dementia, that's where we're really starting to see some changes where, hey, at that point, somebody has probably taken over management of finances, right? Somebody is paying the bills for you. You're not driving anymore most of the time, and you're needing a lot of assistance managing those day-to-day things, okay? And so as you can see with cognitive stuff, so with the dementia, all those things that we kind of take for granted of like, hey, my ability to focus on a conversation, or even just, I'm out at dinner with family and I'm trying to order from the menu, and I get so confused and I'm cognitively overwhelmed to where I can't even order my own food. Those things that we often take for granted, dementia impacts all of that, okay? And it gets progressively worse as the disease goes on. On the next page, so we have our slide on the imaging stuff. And so this image really is an illustration just kind of to show that we can pick up on changes of what's going on in the brain when people have Alzheimer's disease, okay? The far left image is a cognitively normal individual. In the middle, you have something called AMCI, which is what we call amnestic mild cognitive impairment. So amnestic, so amnesia, so I'm forgetful, right? Because that's the hallmark of people with Alzheimer's disease. They're forgetful. You have a conversation, you tell them something, and they forget it, 20 or 30 minutes later or something like that. Well, what we know is that once somebody's in this AMCI range, it's not always the case, but we can pick up on changes in the brain when somebody is starting to progress, okay? And these areas in the brain called the hippocampus, okay, and the medial temporal lobes, where we start to see shrinkage, okay? And you start to see shrinkage, and you also start to see shrinkage in these areas in the brain right there in the middle. Looks like some more black spots or a black space there. That's where the ventricles are, okay? And the ventricles are important because they get rid of waste products in the brain. And you can see, maybe from your own slides and the other one, the ventricles, the black space in the middle of the middle picture, they're larger, okay? And they're going to get larger, as we age, just because our brain shrinks. Everybody's brain is going to shrink some, okay? But that's really large, meaning that we're seeing some kind of abnormal shrinkage, okay? And that also helps us to see, okay, there's some changes going on in certain areas of the brain that are hallmarks for Alzheimer's disease, okay? And so the hippocampus, the temporal lobes, those are areas of the brain that are important to forming new memories, okay? Not just your old memories. Sometimes I get patients come in or their family members and they say, well, they can remember, my wedding, and they can remember this about, all of these things. Long-term memories are typically more spared in the early parts. It's the learning new stuff, okay? So let's say instead of having to go pay bills in person all the time, now I have to send in a check I have to learn a new task. If that family member has Alzheimer's disease, they may have more difficulty doing that or may not be able to do it because they can't learn that new task, okay? So it's the inability to learn new information, okay? And that's why sometimes it seems like, well, they're able to function fine, but it's like, okay, if there's let's say for instance with driving, they go to church every day, they take the same route every day. Well, if there's a detour or if there's construction and I got to take a new way, that family member might have some difficulty, right? And so learning new tasks can potentially can show you that this person is having some more difficulty, okay? So on our next slide, the screening. So, okay, we're given all this information. How do we go get ourselves checked out? Well, one of the big things is an annual wellness exam, right? So as part of, especially for older adults, part of that initial annual wellness exam, providers, your PCP, your family medicine doc, they will start doing cognitive screening tasks and asking you questions about your memory and thinking, because we know that, hey, this is a time when we need to start asking these things, okay? Oftentimes, family members might bring it up and say, hey, I've noticed that you've had some struggles or some difficulties. It might not be that they're trying to be nosy and that they're trying to take over things, but it might be that they also have some real significant concerns, right? And so there's also blood tests that we do that help to pick up on aspects of Alzheimer's disease. There's some things that we can test for. And then, of course, the imaging, right? And so sometimes you can see changes that are associated with Alzheimer's disease. And so there are ways that providers can go about helping patients to understand what's going on with their brains and figuring out what to do next. On the third slide, so primary care cognitive testing. So most everyone in here hopefully has a PCP or family medicine doc that they go see once a year, hopefully once a year, twice a year, whenever. And they do these routine screenings, okay? Typically around the age of 65, every time you go see your family medicine doc, you're gonna have that same kind of test. I gotta do that test again? Yeah, you gotta do that test again, right? And that's part of the process. And so they're also gonna be looking for if there's some reversible changes that could be impacting your thinking. One of the big ones, vitamin D, right? Research has shown low vitamin D is associated with, like, people can have some cognitive changes. You give them some vitamin D, potentially those cognitive changes will go away. So there's some things that are even just, hey, if we just take care of these things, you might actually have some memory improvement, okay? And then there are certain cognitive tests where we're actually gonna, it's like a screener, right? It's like you go get a blood test and they say, hey, there's something abnormal in your blood. We need to go send you for, further testing. We have cognitive screeners. They're like 5 or 10 minute little tests where we ask you about who the president is and what day of the week of it. Has anyone ever had to do one of those where we ask you all these weird kind of questions where people are like, I don't know why they're asking me those things. There's a purpose, there's a reason. It helps us understand how someone's brain is working, okay? And we look at all of those things to help us to figure out, like, hey, does this person need to go get further workup? Do they need to go get further evaluated, go see a neurologist or Dr. Schmidt or myself to figure out if we're having some more cognitive issues, okay? So we'll go to the next page. So the fun part about our job, or for me at least, is when patients come in and we get what we call worried wells, which are patients who are aware that like they might have some cognitive changes and they are worried that, oh my God, I think my brain is going and I'm just having all these memory issues and this is going on. And I love having those conversations and because part of my job is like a detective. I get to ask questions, pick apart of things. Okay, what does this look like in your day-to-day life? So there's some normal aging changes that we all experience, and then there's some that are not normal, okay? And so on this slides, forgetting the name or appointment, but remembering them later, right? Forgetting my name, but then when you see me a couple times, you remember, oh yeah, starts with an M, Dr. McBride, right? I'm horrible with names, right? But if I get it 2 or 3 times, I'll learn it. But immediately, don't ask me to remember any names. Making occasional errors while you're balancing a checkbook. I'm off by a digit or so, right? That's normal stuff. We all experience that. But having difficulty following a plan or working with numbers to where, hey, I've let some bills go unpaid for 2 or 3 months, even though I had been paying them for 3 or 4 years beforehand, there might be something going on there, okay? On the next slide, again, what is normal? So misplacing things. Anybody in here misplace things? All the time, right? But then what's not normal is you're losing something and you're not able to retrace where you put it, and then sometimes accusing others of taking things from you, right? So that's taking it a little step further. It's like, I know I put it here. For me, it's usually things are in a safe place. I just forgot where that safe place is, right? So I put it somewhere smart, but then I completely forgot it, okay? And so, occasionally being, weary of work, but then where we're seeing not normal changes is when somebody is, things that they previously enjoyed, like, hey, participating in Bible study or things like that, where like they were the go-to leader for Bible study and they just don't want to do it anymore, right? So those are some of the types of things that we see oftentimes where people are having more difficulties. If you have a family member or someone who, ends up saying, hey, I want to go get my memory or my thinking checked. What we typically love to see when people come to the doctor is bringing a family member, a friend, or someone who helps in your care, because believe it or not, sometimes people with cognitive issues are not aware of the severity or how big the cognitive issues are. You wouldn't believe how many times some people come in and say that the patient says, oh no, I'm doing great. And the family member is like, no, they just got lost and we had to call the police to try to find them, right? And so it's not that the individual is necessarily wanting to just be like, I don't want to deal with it. We oftentimes can lose that sense of awareness of what's going on with us, okay? A list of questions or problems that you are picking up on. Oftentimes we're talking about emotionally charged topics, and so sometimes when the family member comes in, I don't even know how to describe it. Write those things down so that when you come in, you have a list of things to say, hey, they did this today, they got lost here, right? So that way you're not having to try to come up with all of that information at once. And then, of course, always medications and supplements, because sometimes people have cognitive issues due to medications, especially as we get older. So your providers are going to want to see and say, hey, what are the things that could potentially be impacting you? Those are the things that you want to make sure to have, but especially that caregiver, that family member, or if it's a friend and say, hey, I want to go to the doctor. Can I just go with you? I just want to make sure, because I know we're so close. I want to go with you so that way you don't have to try to tell me what the doctor's mumbo jumbo is. I get to hear it for myself, right? And so I'll turn it over to Dr. Schmidt in terms of talking about what to expect and some of the treatment options that there are for Alzheimer's disease, especially once you get in the door and you start picking apart, okay, what's going on with that individual.
Hello again, everybody. Thank you for letting us come and visit with you. It's always a pleasure for me. I've been working in the field of Alzheimer's disease now on to 45 years. So just to give you my perspective, what we've developed over those years. When I first started, I would see people who said, "Hey, Doc, I've got a granddaughter who's single. Are you single?" And I would go through some of the things Dr. McBride talked about. And at the end of the visit, they would go, "Did I ask you about being single so you could date my single granddaughter?" So as I did more work in the field and was in clinic, I grew older. So suddenly it was, "Hey, Doc, I've got a daughter." "I've got a daughter. She's just your type." And then it would happen again. And now that I'm well over 65, when I see people who have memory and thinking problems, possibly Alzheimer's disease, they say, "Hey, I may have lost my husband 5 years ago, but why don't you and I go for a date?" So things have changed in how we diagnose and treat Alzheimer's disease. One of the things we've learned, and are learning much better and hopefully will understand more, is the old saying, and you all know this saying, "An ounce of prevention is worth a pound of cure." Exactly. And that's where we're headed. But let me talk about how we have gotten there. When you go in for a workup for memory trouble or thinking trouble in general, we're going to ask questions, as Dr. McBride suggested, about what medicines you're taking, how well you're sleeping. We're learning that there are a number of things that can lead to memory and thinking changes and loss. Poor sleep, sleep-disordered breathing. All of these things will be tapped into by whoever the medical professional it is that you see or a family member sees. And as Dr. McBride mentioned, there'll be other tests. We're going to check blood work, we're going to check urine for anything that we can treat, like kidney disease, diabetes. All of those things affect how you think and remember, particularly as you get older. And the key is always understanding where the symptoms are. Because as you saw in that one slide with that long arrow showing the different stages of disease, we have learned that the changes that result in dementia can start 10 to 20 years before you see the symptoms. And this is where that annual checkup is so important. Keeping your blood pressure in control is so important. If you don't, it increases your risk for dementia downstream, whether it's based on a stroke or just hypertension or high blood pressure as a general risk factor for dementia. So getting a complete picture of the person's health is critical. And we've learned this over the years. It's one of these conditions that sneaks up on you. As Dr. McBride mentioned, it's insidious. One day you may forget to pay the bill. 3 months later, you're forgetting to pay 4 or 5 bills. That's the time that you're already showing symptoms, which means that the changes that Dr. McBride showed in that MRI slide with the 3 MRI slices, those changes are already on the way. And what are they due to? And this is what we've learned. So back in the 1980s, we learned that the brain loses a very crucial component of nerve cells. There's an area in the brain called the nucleus basalis of Meinert. You're all going to go home and you're going to have this term and you can impress your friends. say, I know about this part of the brain called the nucleus basalis of minor. And you'll say, and the reason it's important is that's where some of the earliest Alzheimer changes are seen. And it's important because it reaches throughout the brain and hooks up how our memory, our short-term memory works. And as the nucleus basalis of minor dies off, as those cells die off, our memory and thinking are reduced. And this was discovered way back, 1980s, last century. But what's important about those changes is we were able to see that there's a certain brain chemical called acetylcholine that this system uses. And so we were able to develop in the 1990s, we were able to treat the symptom of memory loss by replacing some of that brain chemical that the nucleus basalis of minor, the hippocampus all require for good memory and thinking. And so we developed from 1993 on forward to 10 years ago, treatments for the symptoms of memory loss. Some people do well on these, they notice a difference, some don't. But in the meantime, scientists were studying what's behind dementia, what's behind Alzheimer's disease. And there's two things to remember. They're both proteins, but they're abnormal proteins. One is called beta amyloid, shorthand amyloid. Amyloid is all over the body. It's an important building block, but because of how we are made, the body makes mistakes when it tries to repair things. And so amyloid, this protein, starts to stick to itself. And as it sticks to itself, it will stick to nerve cells. And in so doing, it starts to kill the nerve cell. So beta amyloid is one of the important proteins that's abnormal. The other is what we call hyperphosphorylated tau. It's easy to remember just as tau. Tau tells us that the nerve cell is damaged when tau starts to stick together. And both of these proteins were discovered only in the 1950s, even though they were discovered back in 1900 by Dr. Alzheimer when he looked at them under a microscope. We just didn't know what those proteins were. We could see them, but we didn't know what they were. So scientists have done really impressive work in the last 25 years with these proteins. And as a result, they have come up with not just treating the symptoms of the disease, but because we see these proteins build up before you get symptoms, we now have ways to flush out one of those two abnormal proteins. We have therapies that take the beta amyloid, that misfolded toxic protein, out of the brain. And it's only in the last 2 years that we've been able to say, we now can treat one of the major contributors to dementia and Alzheimer's disease. So this is why it's so important to get that early diagnosis. The earlier the diagnosis, the more likely it is we can get that protein out of the brain and protect the brain. That's what's really neat. And there's 2 medicines that are currently approved. There were originally 3, but one of them had a bit too much side effects for the brain. They're called lecanemab and donanemab, or donanemab. Let me pronounce that correctly. And then there's, of course, like every medicine, there's a trade name, Leqembi and Kinsella. And to get it into the brain, you have to get an IV infusion. But many of us have had IVs before, so we know that it's not so bad. You may remember the last time you had a colonoscopy, they put it in an IV to put you to sleep so they could do the exam. But what these drugs do is they remove those beta amyloid plaques from the brain. In rare cases, you get some brain swelling. Maybe 1 in 20 people. And so what they do is they do repeat MRIs. They repeat the MRIs to make sure you're not having a side effect. And interestingly, one of these medicines is likely to get approved for not just IV infusion, but after you've had the IV infusion, you can just get a shot to sustain the effect of the medicine. So what's critical, again, is early. One of the things that I've done for years, and as you heard Dr. McBride, sometimes it's like being a detective with family and members. What's going on? How do you talk to people where you think their memory is not working? It's beyond what we see with usual aging, growing older. Right? You saw the little slides that Dr. McBride showed of what's normal and what isn't. Right? If I leave my wallet out on the table, normally, but one day I come into the house and I put it in the dresser drawer for safekeeping. And I go back to the table and I can't find my wallet. Do I remember I put it in the drawer, or do I say to my wife, "Why did you steal my wallet?" Okay? That's a significant memory problem. And I'm trying to figure out why the wallet isn't where I think it should be, and it's natural to assume somebody took it, or the dog got it and chewed it up. Something. Okay? Those symptoms are the ones we want to treat. We can treat symptomatically, and in the right situation, we can treat ahead of time. But the key is how do you talk to a person? This is a very sensitive matter. We are what we remember, aren't we? We are what we learn. Okay? I'm always impressed when I come to a church, and I want to point this out. You all know this, but it impresses me. This do in remembrance of me. This is the core of our faith. This is the core of who we are, is remembrance. How we remember. Remember who we love. Remember who we've lost. Remember who the new person is in our lives. Okay? This is the key. So we want to treat and protect memory and thinking. And with these new medicines and our awareness of the risks, as Dr. McBride talked about, it's important in the African American community to raise awareness, to not just say, your memory's not good, that's normal for growing old. No, it's not in all cases. And if it's severe enough, we can do something about it. So some of the things we have these guides, and a church is always a good place. Pastors are even better. They're trusted people who care about you. So part of our mission is educate pastors about this disorder. Finally, what else do we do for congregations? And through our work with the DKB Med people, the continuing education, we are going to try to set up a health fair screening, which if you've been in the congregation here and worked with Dr. Rodas, you've experienced this. But we want to do it on a larger scale so that people can experience what it's like to just get a screen for risk factors for dementia. Your blood sugar, your blood pressure, your BMI, your cholesterol levels, those things that increase your risk. We've been doing this for years. We have a program called Know Your Numbers, where we do a screening and you're given a little card and we put the screening values on it. There's no identifying information. It's you and you alone. And by putting those numbers down, the next time you see somebody who is your healthcare professional, whether it's your primary care doctor, a nurse, or whoever, you can say, hey, I did a health screening. Here were my numbers. How do they compare to today? That's important to keep you healthy and keep you going. Finally, We also privately, I have a group memory test, which I thought about bringing today, but chose not to. I can screen 100 people at once for memory trouble. Believe it or not. But that's the first step of the screen. Then if a person is concerned, we will set up a private appointment to see somebody such as myself, Dr. McBride, or somebody who works with us, who's an expert in these 5-minute screenings, to give that information back, because it's important. So, we did want to leave time for questions. I see nobody's taken a nap after lunch, which is good. You're still with us. So we also have, I hope, on Zoom, Dr. Ima Ebong, our colleague in neurology, who is a fantastic neurologist and community educator who specializes in brain disorders, in particular epilepsy, but she's with our group now doing healthcare outreach. So hopefully she's online so that any tough medical questions she can tackle. But Dr. McBride and I will tackle other questions from you. So thank you for listening. God bless. Nope. Just doing my job. Thank you, though. Questions? There's no question. Let's try not to. We'll keep questions impersonal, if you will, if you have any.
The infusion, the medication, the IV infusion, is it very expensive?
Okay, good question. The IV infusion of those medicines, is it very expensive? And it's a matter of what's very expensive in your mind.
Well, is insurance going to automatically pay for it?
Insurance does pay for the procedures and the medicine now. Beforehand, it was estimated that the medicine would be about $25,000 a year. But insurance now covers the diagnosis and the treatments and the monitoring. Yeah.
Do you have to be so far along with like your MRIs and stuff to start the IV?
Yeah, so the question is how far along do you have to be in the diagnostic process? So the answer is generally yes. You want to be early in the chance to benefit from treatment, which means getting more tests is good. So generally what will happen is you'll have all of those things done by your primary care doctor. The blood work, right, the memory screening, they might order the MRI. And at that point, if everything's pointing in the right direction for treatment, then you might get one of two options. You can get what's known as a PET scan, which now is available, that tells you how much of that bad protein is in the brain. Or you can get, and we're working on getting a blood test for this, but you can get a spinal tap, which will tell you. Then, based on the results of where, how much of that bad protein have you got, then you can be eligible for that if there are no other medical conditions that would get in the way of that therapy. And then you would go in every couple weeks, get your infusion, and get an MRI to make sure you're not having side effects. Yeah, it's an involved process. But on the other hand, as Dr. McBride and I were talking about this morning, what's the value, right? How many months or years are we getting back from doing this?
Before your presentation, I was like, I'd rather not even know. And so now after listening to you, I think I do want to know. Because I know that there are screens that will tell you if you carry the gene, correct?
That's correct. That's correct. So yes, there are screens that will tell you if you carry a risk gene, apolipoprotein. There are other genes that promote Alzheimer's, as you point out. Generally, if you have one of these genes and mutations, you're developing Alzheimer's in your 30s. So nobody here is in their 30s, except maybe Dr. McBride. On the cusp. So yeah, that's part of part of the risk is checking into that. It's not needed in order to qualify for that therapy, though. We do know that depending on what your genetic makeup is, on the apolipoprotein E4, that gene that you may have could increase your risk for side effects or not. So at some point, we do check for that.
Is there any other medication, like if you didn't have the brain swelling, is there another medication that you could take? If, you know, since you couldn't take that without the brain swelling, there's another medication that you can take, right, that would stop the process, I guess?
So the question of if you experience a side effect with brain swelling, is there a medicine you can take to counteract it? The answer is yes. Normally, physicians will use steroids for brain swelling. It's often done even after brain surgery to reduce the swelling. But generally, just by stopping the infusion, you can reverse it. The side effect occurs. Some people only notice it when they get their MRI. So that's why you would have several MRIs to make sure that the swelling, A, doesn't happen, and B, if it starts up, just stop the infusion for a while and it goes away.
Right, but is there another medication other than that infusion that you can take?
For treating your memory?
Yeah, yes.
No, not from the standpoint of getting rid of the abnormal protein. You can take those other medicines that I mentioned before that are symptomatic therapies. So the most common known ones are Aricept. That's the one that's most commonly known, and Memantine or Namenda. Those are the most common, but there are others. Prevagen's over the counter and has it's a good placebo in my book. It's a good sugar pill. It's a $50, $60 sugar pill. There's a huge billions of dollars being made on people who worry and won't go see the doctor. And they just go into the drugstore or buy off of a TV ad. The evidence that any of these things really works is very limited. And I even have a good colleague who shall remain nameless who has his own product line. And the evidence for that product line is not convincing to me. But I could go and get trained by him in how to do this. It would only cost me about $50,000 for the training. Yes, ma'am. Yeah. So yeah. Yeah. So the question is how do you advocate, being in the African American community for yourself and for others to get those tests? You just come right out and ask the doctor. It's supposed to be part of your annual wellness examination. They're supposed to check your memory and thinking. They're supposed to look at you as a whole person and look at what medical conditions might make your thinking a little less sharp. Advocating for family members, the same thing. That's why we often, like Dr. McBride and I, love to have family members come visit with us when we're doing a workup for a suspected neurologic problem. That's part of the advocacy. And that's where introducing the topic and saying, maybe we ought to go get checked is so important, because we can, I rarely get excited, except when I think somebody has dementia and we find something that's reversible or treatable. That makes my day, because we can reverse, in some cases, those problems. So I'm going to let Dr. McBride add to it.
And I would think about it also as your healthcare provider is there to serve you, in the sense that if you got to twist their arm a little bit, and sometimes you have to make the case for I have a strong family history of cognitive issues in my family. We have a lot of health issues. I know this impacts my community more than others. I really need you to make this referral for me, And then if that doctor is not willing to necessarily maybe have a conversation or even kind of convey why they're hesitant of making it, outside of like if I have diabetes or high blood pressure and I'm, in those 50s and stuff, and I'm starting to notice some cognitive changes, what's the harm in that doctor making the referral? Right? That's your healthcare dollars working for you. It's not money out of their pocket necessarily or anything like that. And so sometimes we have to, Dr. McBride, I really need you I need you to help me with this. These are the issues that are going on. And, being your best advocate as well for your family members as well too. Because, we sometimes get so inundated in what we have to do and our focus of these are our priorities. And then it's like, I need you to add this to the list of priorities. This needs to be done.
Sometimes when people have seizures, they can have a memory loss surrounding the seizure themselves. They don't remember what happened right before the seizure or right after the seizure. And so I have diagnosed patients who presented to general neurology or even primary care with concern for dementia, but they were just having seizures that were undiagnosed, and we captured them on an EEG, an electroencephalogram, where we look at patients' brain waves. So that's a really great question. What all needs to be done before we diagnose someone with dementia? There's lots that need to be done, and depending on what the patient tells us, what their family members tells us, so the history, of course, and our physical exam, it'll drive our, all the testing, it'll drive what test needs to be ordered so that we can come up with the appropriate diagnosis.
Can I add something to that too, Dr. Schmidt? And so to add to what Dr. Ebong is saying, once you're seen usually by the neurologist may refer you to the neuropsychologist in addition to doing those testing. And so you'll come see us potentially after the neurologist has said, hey, concerns for cognitive decline, we think it might be Alzheimer's disease. Our neuropsych testing is part of that evaluation process to help solidify the diagnosis for Dr. Ebong so that then she can prescribe the right appropriate medications or appropriate follow-up. And so with our evaluations, it's separate from the neurologist clinical interview where you might come in with your partner or family member, and then we do cognitive testing, and we try to do all of that in one day. We write up a report, and we give that report to Dr. Ebong and say, hey, this is what our results look like. This is what the memory profile is. It's consistent with your conclusions, or it's not like that, And so we put all of that together to help put the puzzle together to figure out what's going on with your memory issues.
Yeah, thank you for adding that information about the neuropsychologist testing. I just assumed that before I got here, I know that you all were speaking, I didn't know how much in depth you went into your testing, but definitely an integral part of the diagnosis of dementia, as well as the diagnosis of mood disorder, because they actually, the neuropsychologists help us determine how much of the cognitive impairment is due to depression or anxiety or any other psychiatric illness. So that's another great example.
Can a person be born with cognitive issues, inability to learn? Is there any way that they can improve after they a certain age? Can that be improved?
So that is a broad question. But the question, again, if you didn't hear it, was, can a person be born with cognitive difficulties? And the answer is yes, for lots of reasons. The most common are genetic disorders like Down syndrome, other things due to birth trauma. Cerebral palsy is a good example. So intellectual disability is a whole nother area of study. And our neurologists who work with children, as well as Dr. McBride and myself, part of our job is to help with that diagnosis, determine strengths and weaknesses that a person may have to develop appropriate educational options. Do you want to add to that, Dr. Ebong, Dr. McBride?
Could you all give us some things as family members that we should kind of just be aware of? Besides, like, we think of dementia and we think of forgetting things, but like some more specific, are there other specific behaviors that we ought to be watching for to help people, that we're serving in that way for early diagnosis?
I think the repeating questions or repeating conversations within a short window of time. And so that short window of time can vary, right? It could be, I saw this person once today, I see them tomorrow, and we're having the same conversation. And sometimes that can be a clue. But you want to ask, okay, if I jog their memory, if I say, hey, you remember we just talked about this yesterday? We were standing in line to go get food. And if they have no recollection of it, that might be a cue or something to be concerned. If the individual is having trouble doing things that they've always done, I've taken the same route to get to church, and there's nothing changed about the route. So before it was, if they have a detour and I can't find my way around, that's a problem. But now the route is the same, and I got lost. That's concerning, right? Because that's what we call an overlearned behavior, right? Where this thing that I've always done, or there's a recipe that grandma has always done, knows it like the back of her hand, and now she forgot to include a really big ingredient, right? So those types of things where this person has been doing this for so long, and now they're starting to have difficulty with those things. Because oftentimes with our older adults, my grandparents are still alive. They're in their 90s. And so their routine is very set, very regimented. They're not doing too much outside of that. If I started to see changes in that stuff, that would raise my eyebrows, as opposed to if I said, hey, Granny, I want you to go down to the waterfront park for the first time in 10 years and go to this fair. I might have trouble navigating in a new place where I haven't been for a long time, right? And so we don't want to just kind of be so hypervigilant about memory issues, but when we start to see changes in stuff that they've been doing for a long time is where my antennas start to go up.
So, we still have Dr. Ebong. Any questions for Dr. Ebong yet? If not, I think we've worn everybody out. Is that so? So, in closing, I have to hand this over to Eddie because we want to remind you to fill out that post questionnaire so that he can hand you, when you trade the questionnaires with him, he can hand you a thank you gift card for spending time with us. We're always available at Sanders Brown Center on Aging. Dr. Rodas is, who you know well, is our up-and-coming star who is taking the screening and healthy aging to the next level. And she works with us. Dr. Ebong works with us. Dr. McBride, we're a good team. And that's nice. It's a nice thing for an old man to be able to say that I have a great young team. Not only are they younger, they're smarter and more talented.
Thanks for watching. We hope you found this program informative. If you're interested in learning more or would like to partner on an educational program for clergy at your church, please reach out to us at info@dkbmed.com. That's info@dkbmed.com. Thank you.